welcome to this session entitled Looking to the Horizon, Australia's R&D Review and the National Strategy for Health and Medical Research. We expect in the next month that the chair for this government-commissioned R&D review and the review terms of reference will be announced, but they are not yet announced as yet. We've been promised for several months that they will be coming next month. They will eventually come, I'm sure. A four-component national strategy development process is being led by Natasha Pollinges, CEO of the AHRA office. These four components are, firstly, a health and medical research workforce audit that's in progress, community focus groups and they're being held, a review of the funding landscape, and analysis of national and international strategy and priorities. Representatives of the Academy attended a closed briefing from Natasha last week. Our panel of experts is here to guide us through what might lie ahead and what we might do collaboratively to achieve a good outcome from this review. I'm pleased to introduce the panel and invite them to come to the stage. First of all, Professor Elizabeth Hartland. Professor Elizabeth Hartland is Director and CEO of the Hudson Institute of Medical Research in Melbourne and Head of the Department of Molecular and Translational Science at Monash University. She is also currently the President of the Australian Association of Medical Research Institutes and earlier this year became a member of the Order of Australia for significant service to medical research, particularly microbiology and to tertiary education. The Academy was also pleased to welcome her as a new fellow this morning, and congratulations on that. The second member of the panel will be Professor Anna Nowak. She is Deputy Vice-Chancellor of Research at the University of West Australia. She's a medical oncologist and a clinician scientist. In her role at the UWA, Professor Nowak is responsible for research policy development and leadership of the university's research activities, industry liaison and commercialisation, things very dear to my heart. The third member of the panel is Professor John Prins. John is an active clinician scientist, a respected thought leader in diabetes and endocrinology in Australia. In July 2023, he was appointed chair of the Australian Health Research Alliance, the national voice of 14 research translation research centres, which are either fully accredited or recognised as emerging by the National Health and Medical Research Council. So welcome to all of the panel. Now, it's my job to start you off with some tough questions. So let's have a nice broad one to start with. What issues must a successful national strategy address to spark off an improvement in health and medical innovation in this country? It's kind of a John question, that one, to start with.
You're too kind. You're too kind, Ian, giving it to me first. Well, I think the key issues are obviously thinking of the health of the community, and I say that as a very obvious thing, but these visions can get lost in the machinery of developing a strategy. The second, as we've touched on a lot today, is to ensure that it's completely appropriate for everybody that lives in Australia, irrespective of their background and irrespective of their circumstances. And again, that sort of inclusivity can be lost. And then third, it needs to be a very evidence-based strategy. Again, maybe stating three very obvious things, but there's an anxiety that these will be lost in what might become a fairly vanilla strategy that isn't actually addressing some of the issues of the day.
Okay, I should point out that anybody on the floor is welcome to ask any question at any time of any member of the panel. And please just, if you want to jump up, grab a microphone and ask away. I might ask along the rest of the panel here what they think about this business of a successful national strategy having to address in the way of getting health and medical innovation off the ground further than we've got it already.
Thank you. Well, I'm going to take the university perspective, and obviously universities aren't in the business of delivering healthcare, but we are in the business of training our healthcare workforce, and we are also in the business of the sort of research that makes healthcare, has the potential to make healthcare sustainable for our population. So certainly like to see some attention to the workforce which has been described. However, we also need to make sure that we are continuing to train clinician researchers, clinician scientists, and that covers the whole range of clinicians, to work alongside scientists with other training backgrounds. And at the moment, we are seeing a decline in the number of clinician scientists in Australia, which is likely to harm our ability to innovate in the future. Secondly, of course, research, the opportunity to view research not as a cost in the strategy, but as something that will support the benefit sustainability to our population and to the healthcare budget in the future.
I mean, we face a real challenge in this area because clinician scientists are scarce enough anyway, and increasingly within the health system they're being clinicians because they don't have time to be clinician scientists. And I don't see an easy solution to that one until people spend sufficient resources to actually increase the population of clinician scientists and protect their training time. And I think this is one of the issues that the Academy really has to jump up and down about, to make sure that there are clinicians coming through the system who are being trained to be clinician scientists. Because if you don't, we'll miss a whole generation otherwise. Any further thoughts on that?
Yes, I guess I've thought about an answer to this question from the perspective of medical research institutes and the pressures that are facing the sector, I guess the business model of the sector, and the fact that I'd really like to see the strategy talk about a sustainable workforce and sustainable career paths for our researchers, both clinician scientists and biomedical scientists. A commitment to funding the entire research pipeline from discovery research through to translation, trials, implementation. I think there's an opportunity to remove overlap between the NHMRC and MRFF and maybe reposition those funding agencies to complement each other better. And also really get the government to recognise the importance of the full costs of research, funding the full costs of research, because we know from our AAMRI members that for every dollar we spend, we need 60 cents or so to support that research. And with federal and state contributions, we now get about 12 cents. So running those organisations is extremely challenging in the current environment.
I shouldn't laugh because it's no laughing matter, actually. It's a very serious business. Questions from the floor? Anybody want? Hand up there.
I think Asha Bowen from University of Western Australia and Perth Children's Hospital. Connecting the two sessions that we've just had, I think that because of that government lack of investment in the additional costs of doing research, we actually, particularly in WA, then rely on the coal and gas industry to fund philanthropically the work that we're doing. And I think that really puts us in great danger and conflict. And I just wondered what the panel thinks about that, because almost everything that's not funded through government mechanisms comes through a philanthropic pathway, but most of that is actually probably what I would term dirty money and doesn't contribute to nature. So I was interested in whether that should be a key part of the R&D strategy as well.
Yeah, I think that's a great point to make, and I'd say medical research institutes and universities probably manage funding this gap in different ways. For universities, it's from teaching income, international student fees, and medical research institutes, rely heavily on philanthropy and commercialisation. So you're right, we have to turn to someone, somewhere, to fund this gap, and I guess that does put our organisations in a vulnerable position when we're trying to make changes to our sustainability.
Thanks, Asha. It's a great question. I think one of the things we can do is ensure that the money that does flow through those mysterious sources does not come with whiskers about how it's spent, or come with And we, as organisations, are often faced, and I'm sure many people in this room will have been faced with a situation where there's an offer of some money which looks like the answer to your dreams have come true, and then you realise, well, actually, I don't have freedom to operate with that money. So, it's not answering your question, but at a very first step, we need to ensure that if money comes via donation or via supportive activities, that the organisation has complete oversight as to how that money is spent.
I think that the challenge we face is the last part of that. The industry is very keen to invest in health and medical research in existing facilities because it's cheap for them. They don't have to build a building and they don't have to look for the equipment to make it work. And certainly in Queensland, we're seeing quite an interest from industry in being a partner to this, but we've got to make sure it's a fair partnership. I mean, otherwise we end up diverting resources from healthcare or from existing funding sources to basically to help industry. I mean, they help us, but we have to recognise it's a two-way system. Yeah, one at the back there.
Flavia, you're first.
Okay, thanks. So I think we're in a really difficult situation because, we've always worried about where money is going to come for research. But, in the recent, 5-10 years, hospital salaries now really go to provide service. There's not a lot of fat in that system. So, clinician researchers, could have a bit of time, etc. That's really drying up. The university system, especially now with caps on international, is going to be tighter there. So that's fine. We muddle along, but I think the biggest vulnerability for Australian science is the mid-career researchers. So I think paradoxically, the NHMR system of investigator grants and all the rest was really neat for those that got them, but it's that transition for the early, once all the older people retire, I think we're unbelievably vulnerable because I'm not sure where those people are getting money from. Like clinical work is work, teaching work is teaching.
We're not allowed to retire. That's the problem.
Thank you, Helena Teed from Monash. Just a question. I don't personally know that I've ever seen a successful strategy to be funded by going and saying, woe is me, we need more money. And I just wonder how much accountability as an academy and as leaders we have around flipping our research paradigm more to be about genuinely identifying problems for the funders of our research, who are our community, and genuinely working together to solve those problems in a way that we can demonstrate clear impact. In other words, if we go with problems and solutions and really train our upcoming workforce around problem and solution delivery, whether we perhaps might position ourselves in a better way than to continually have the lived experience we have, which is around the fact that we're underfunded.
Thoughts on that?
I think we're increasingly seeing a push towards mission-based funding, and certainly the National Science Statement and National Science Priorities, which have already come out, which do mention health and medical work as well, but that's very much driving towards mission-based funding. And we already see that with the MRFF, but it wouldn't surprise me if we see this strategy moving more wholesale towards mission-based funding, which has some benefits because in health and medical research we are good at working in silos, particularly around disciplines or organ systems. So we have some opportunities to change up what we do through being more collaborative.
Perhaps just as a final point on that, in the UK, 25% of the organisation's funding is based on impact. We're moving in that direction, but it's not our metric at the moment. So likewise, how do we shift, besides missions, how do we help our sector shift towards that impact agenda?
I think one way to do it is the phrase I'm trying to get off the ground very unsuccessfully is in line with sort of the things that Rachel and others talked about in low value care. We should be considering at a government level low value investment. and that's investment in research and investment in education and investment. So are we teaching in our universities the right things? Are we researching the right things? Are those activities actually impacting positively the public? And so that's another way to look at it, and that can come into a strategy where that's an important part of how we do things. The other area where I think, and I completely agree with your collaboration, I think everyone here is on board with that. The other area is to actually make better use of the stuff that's already going on, and this came up in the AI presentations this morning. So the greater the proportion of the healthcare workforce in its broadest sense that can embrace AI sensibly or can do good quality assurance or good quality audit or good non-sexy things, but that can make a huge impact, then that's another thing that could be built into the strategy. So this becomes business as usual, and we saw it in the climate presentation as well, that we need our boards to be thinking of sustainability as well as the financial bottom line. We need our workforces to be thinking about using the information we have intelligently and with academic rigour, with the sole purpose of improving the health of the community.
Hey, thanks everyone for the comments. I just have a question around going for this large-scale mission-driven and also impact-driven research. If you look at the history of research, a lot of the groundbreaking discoveries and transformative things have been made by small groups, and because they're thinking differently to the rest of the people. And so how do we, construct research in a way that's been described here, but also maintain that ability for innovation to make those groundbreaking discoveries that are against the grain?
I think that one part of that is to make sure that people are funded without a particular target in mind for the research funding. Obviously, I always think about the vaccine I was involved in developing in regard to that, because we certainly were never funded to work in the area that produced the vaccine, or even in the technology that ended up producing the vaccine. So yes, giving people a bit of freedom to do what they want is important. And let's be fair, the NHMRC fellowships, once you get them, you're free to do what you like. You can go off and do anything completely different, and with a bit of luck for 5 years, you'll get off with it. But it is difficult for people to switch mode like that. We have to make it easier for them when we can. And that comes about by being in an environment where all of the necessary support is there, so that you're very unlikely to do it if you're a single person working in a back shop, but you might well do it if you see somebody else that sparks off ideas in you. The other part of that is to make sure people get to go to meetings. They fall off of the system very quickly when money is short, and if the young people don't get a chance to see what is going on in the field and elsewhere, then they lose out on that, and they can only work in the environment they understand. Now, there's another question over here.
Yeah, Phil O'Connell from Westmead Institute Medical Research. So I just wanted to take a slight switch into commercialisation, because if you're running a research institute, one side of you thinking about philanthropy, but the other side's commercialisation. I was wondering about the ecosystem of that and the workforce, because the other thing you think of in the institute is what your biomedical research is going to do. So when I was in the States, people were doing PhDs, and not everyone's, let's face it, not everyone's going to get an investigator grant from the NHMRC, but there was this whole ecosystem where people could go into biotechs and startups and have quite good jobs, using all the skills they learnt and the processes they learnt doing their PhD. Here, they go work for a bank because they're smart people and they need to pay the mortgage. So I was thinking, if we thought enough about public-private partnerships in funding that gap from out of the research academic environment into business, because I think private equity's got an important part to play with that. There is an area where the government could partner with private equity in those space. And the other thing, should our institutions be more flexible in letting people who've got a good idea go out into industry for a while and then come back? Because not everything's going to win. And I think that the trouble is a lot of countries are successful at this. They celebrate failure. We punish it severely. And I think we need to have a flexible work area, and I'd be keen to get the panel's view on that.
Comments on that?
I think speaking from the academic perspective, there's a whole culture change that's needed, and part of that culture change comes from people in this room, because when we reward track record in competitive funding, we are generally rewarding a standard academic track record that includes a lot of publication and not so much commercialisation. We're starting to reward commercialisation in universities, in academic promotion processes, and also to look at how our PhD students can have PhD plus experience, and that plus experience might actually be around some innovation training, commercialisation training, or it might be around teaching or something else, but something that gives them an additional pathway other than the traditional PhD pathway. But you are also absolutely right about that gap in funding between the idea and the commercialisation, and I agree that there's probably a role for government in more readily available patient venture capital, because we need that patient venture capital that can sit around for 4 or 5 years.
Yeah, I think I'd just like to add to that I do feel more optimistic about commercialisation in Australia, seeing what's happened in the last 10 years. And I think you had explained to me once that for a great thriving biotech sector to happen, you need great science and research, and we have that. We need access to venture capital, and that, you know, wasn't there sort of 15 years ago, but it is there now. It's still challenging to get very early stage seed funding, but I think that's improved a lot. We need a good business development workforce, so people who really understand how to take things through to a commercial endpoint, and that's, I'd say, still kind of challenging. We're underdone in that, but we also need industry as the acceptors of our inventions, and you know, it's great that we now have Moderna and BioNTech and companies like that coming to Australia, but yeah, we need more industry to really create that pathway that you're talking about, I think, where people can take time to go into industry and then come back into academia and have that partnership. So they're my thoughts.
Yeah, Phil, completely agree. One of the things that the federal government's already discovered in its homework preparing for the R&D review, which they're about to announce the terms of reference on, is that the major gap in the R&D expenditure in this country is in big business. And the government's view is that Australia's contribution to R&D is quite skewed by international standards, and that the business investment in R&D is in small and medium enterprises in this country, whereas in lead countries around innovation, it's the big business contribution. So that comes back to a business environment that wants to play, and I'm not for a moment suggesting that they aren't trying to play, and they are, but I'm with others. I'm very optimistic. We are seeing changes, we are seeing improvements. I think we run the traditional English PhD model, which the Americans laugh at, and in the US model, if you go to the Stanfords or the Harvards, there's a compulsory industry rotation with every PhD student, and it's a more coursework type approach for the very reasons you elucidate, and maybe we should be rethinking that at our university levels. And at my understanding from 2 universities in the last few years, there's not really any appetite to consider that option at the moment.
Yeah, I think there's a lot to be said for having a scheme whereby recent PhD graduates get a chance to go into industry at no cost to the industry. Obviously, they need to be salaried somehow. And there was such a scheme for a while. I've had at least 2 students that went through that, and they came out the other end, interestingly enough. One went back into industry and one went back into research, so they both found different things that came out of that. The problem was that the funding was tied to an agreement which came to an end, and then there wasn't any further route of doing that. But yes, if you've got to give people an exposure to what's there. The biomedical researcher who has not done a medical training needs to find out how medicine actually works, because otherwise they come up with solutions to things that aren't problems. And I think it's an educational process, and that comes about through close proximity much more easily than by any force majeure trying to make it happen. If you put the right people in the right place at the right time, they talk to each other. At the back there.
Hi, I'm Gillian Mason from the National Disability Research Partnership, but also from Health Consumers New South Wales. I think your comment there is a great segue into my question and musing, which is around the great opportunity we have to reduce low-value investment by involving community members and patients for their knowledge and expertise. I feel like missing from these strategic discussions and from strategy planning is maybe a strategy around a mindset shift of thinking of patients and community members as the beneficiaries of what we do, whose voices we want at the table sometimes when we need a perspective, or we get to the point where we're going to co-design an intervention that's pretty much though already been decided on. But there's this huge value in reducing all of the work that it takes to wait till the end to get some patient perspectives by thinking about how we strategically include patients and consumer representatives as part of our governance structures and from the start as co-researchers. And I just feel I would like your reflections on what you're experiencing, because I feel like it's a way easier problem to solve than we would like to think that it is. There's a caution or I don't know what it is, a dis-ease about, not a disease, but a feeling of dis-ease around conceptualising consumer leaders and patient leaders as leaders, I guess, and not then only as part of a consumer advisory group or a patient group who's asked for feedback.
I'll have a go with that. Look, I do think that that's a much more prominent consideration particularly in MRFF grants, to include consumers and as you said, include them from the beginning and in the design of studies and have that really valued impact. I think the NHMRC handles this sort of fairly well as well. There's a consumer advisory committee that reports through to council. So I think there is growing recognition that it's a really important part of, particularly some kinds of research, population-based studies or very clinical studies, including patients from the beginning. Anyone else want to?
We don't know the composition yet of the group that is going to lead this strategy, but there are many opportunities for consultation, and really it wouldn't surprise me at all if at the end of this the health consumer experience is actually at the centre of whatever strategy comes out of this. But I think some of this is going to be can be driven, at least in research, by funders, and although we have seen many funders moving towards a central role that is mandated of health consumers, the NHMRC still don't have a place for a clear requirement for health consumers to take part in funding processes with the researcher.
Again, terrific question, and I'll be optimistic again. One of the new joint committees for NHMRC MREA is entirely a community-based, consumer-based committee, so that's a terrific start because that committee will then enforce how the money's distributed, if you will. The other part is around education, and the organisation that I represent, the Health Research Translation Centres, actually has a national program around training not just researchers about how to involve consumers, but also how to train consumers about how to effectively engage with researchers, because that then makes it a much more efficient process, because there isn't that long learning curve where you're sort of trying to figure out what the others are doing. You can really hit the ground running. So there's, I think, an opportunity for us collectively to ensure that we have an informed consumer base that can interact effectively with the strange ways of researchers and the strange ways of policymakers, etc.
Hi, Kaz Thursky, University of Melbourne. I wonder if you could comment on the time cost of grant preparation. So with MRFF calls, NHMRC calls, and many late nights and overnights and exhausted people all have post-traumatic stress by the end of the year. Can we move to a system whereby there can be a stepped EOI process, some forward strategy about, key mission areas that need to be addressed, so that we can perhaps have a more streamlined and measured way that we can get the best outcomes for our grant preparation?
Well, I feel like this grant burden is really related to success rates. So because our success rates are so low, then researchers are now constantly writing grants to try and get funding from somewhere, anywhere. So where previously it was just the NHMRC that existed with one, deadline a year, now there's MRFF popping up all the time, several different NHMRC deadlines, ARC if you're eligible for those. So it's kind of relentless, and because people are desperate, when we have a funding rate of 10%, then they are spending those hours just writing, and I couldn't agree with you more. It's something that really needs to be looked at in a strategy.
We have seen the ARC move towards two-step processes this year for the first time with a couple of schemes. So if the NHMRC and MRFF are listening to what happens and watching the lessons learnt, I guess we'll find out if that's been a positive experiment for researchers and for the funder.
Should we not consider moving to the American system where the lab head has the funds and he or she then decides who will work with him or her? And then that's fine until, of course, the person who's the head of the group suddenly doesn't have funds. And if you're at Harvard and you lose your funds, sorry, you're out. You pay for use of the labs by the square meter. And so you've got to have your grant. But it does have the advantage that you can build up a team and expect to keep them. It's not perhaps so good for their ultimate development as a group leader, but that's a matter then between the actual group leader and how he or she runs a group.
I'm going to step in there and say that from a university perspective, that is one of the ways that really challenges succession planning, causes really great people who could be collaborating for incredibly productive partnerships to go their different ways to different universities, and splits up research groups. So I think that would give a series of perverse incentives for the behaviour that we don't want in Australia. That's my personal opinion.
Kaz, a terrific question. I think NHMRC and MRFF are seriously considering a more iterative process. So if you don't get the grant, you don't go back to a clean sheet of paper next year, but there's a consideration about how it might be improved or which aspects of the grant might be funded. That's a very active discussion at the moment. And again, the NIH does this in some of its programs already. So that would at least save some of the waste and some of the effort. And because and we all know, many of us recycle the same grant a few years in a row and hope that the panel changes and you might get up, and that's again a waste of time and waste of effort. So a more iterative process, and that's an area where the Academy may well take the opportunity to really try and influence the thinking about, again, it's low value investment. It's a waste of time is another way of expressing a low value investment. Yeah.
I mean, we're not doing it right when we only get a 20% success rate on average. Something is wrong there. I'm not quite sure what exactly that is, whether it's our ability to select appropriate people to work in a particular environment, whether we just don't train them right. I mean, I was going to say it's not rocket science at the end of the day. At least quite a lot of what we do nowadays is not rocket science. It's data gathering, it's data processing, understanding the data, and then testing hypothesis against the data. And that's a team effort by and large. Now, how many times do you see a project which is just run by one person? I mean, that's a rare event, and yet the funding doesn't come that way. So there's a disconnect between a funding model and a research model, which probably isn't in the best interest, particularly of the younger researchers. So I think that's something that we could actually address quite seriously and try and build a protective environment for training, and also point out to people that not everybody can do research all of their lives. Many people do research for a period of time and then go do something else. They can always manage the research office in the university. I've got to watch what I say about that, because that's a hot topic most of the time too. But I think there's a lot to be said for thinking about where career paths actually end up and who should stay in research throughout their career, which I've managed to do, much to my surprise. But sometimes it doesn't work that way.
So I was just interested the thoughts of the panel around working with politicians. So because I think many of us spend most of our time trying to make the case around impact and unmet need, which is often about trying to advocate for a slice of the pie, that kind of health research pie. My impression from working with politicians in the UK government is research is of less interest because it's a sort of long-term duty, as they see it. Whereas if you mention words like innovation, they see sort of near-term opportunity. And if you move from talking just about health, but also health and wealth as being linked, that seems to be the sort of language that we need to advocate to increase the size of the pie, rather than to advocate for a slice of the existing pie. So it's just interested, clearly a lot of thought is going into this being the National Strategy for Health and Medical Research, but is there thoughts around how you engage with politicians and also whether you link innovation into that space?
I think one of the most wonderful things that's happened in health and medical research in Western Australia in the last few years was splitting up the ministerial portfolio for health and health research and innovation, because the Minister for Health has been so busy delivering care in a pressured environment. A Minister for Health Research and Innovation, who happens to hold a lot of other portfolios as well, has been much more present, and really organisations like the Academy and other professional groups, universities, do have the opportunity to build relationships first before we make an ask. And I think those relationships give us a seat at the table where the decisions are made for at least at the state level.
I was just going to say that a similar thing happens in Victoria, where medical research is more in what's with the Deputy Premier, but in the sort of innovation portfolio, and there is sort of pros and cons. When it's in health, it's lost, and actually that's the situation we have federally. But in every sort of approach to government, we always point out the economic benefit of doing health and medical research, that every dollar spent on research returns $3.90 or so, back to the economy. So they're fully aware of the benefit, I would say, but I'd also say there's no votes in medical research.
Sorry, Ian, I'll just add, I think we've been using the wrong narrative, as the marketing people tell us. We all talk about research saving money. It doesn't save money. What we should be talking about is research improving the health outcomes for the same money. You don't free up a hospital bed because there's 25 people on the waiting list for that bed at any one particular time. So no point talking to hospital systems or primary care systems about lower cost when there's huge demand around. So it's got to be a value an outcome discussion, that if you include better quality research, innovation, audit, all those things that we've been talking about all day, then you will, for the same money, benefit a greater number of people, or benefit the same number of people in a better way or a greater way. So it's a different terminology that we have to use, and because you'll immediately turn, in my experience, you'll immediately turn any politician or health hospital leader, and I've run a hospital, I know what it's like. Don't tell me you're going to save me money, because I can't, I don't have enough no matter how much you give me, type of thing.
Further questions from the floor?
Thank you. I'm Fiona Wood, Burns Service in Western Australia. Just following up on your comments there, I think we all understand in this room that there's lots of evidence that if you're involved in a clinical trial, your outcomes will be superior. So why are we in the back room apologising when we go to get consent from a patient? Why are we still in that space? I'm just interested in your thoughts on that.
I might start. We did a study in Brisbane a few years ago in adolescent health service about whether that group of individuals and their carers would be comfortable with opt-out involvement in medical research, including clinical trials, versus an opt-in process, which is currently in place. We did a lot of work with the consumers, and we crafted the consumer, the statements and the information sheets. And to cut a long story short, 75% of those parents, it was mainly mental health, a lot of police involvement in the care, very tricky area. 75% said they would be completely comfortable with an opt-in arrangement. When we asked the 25% why they said no, about half of them said they didn't understand our information and consent sheet, despite the fact we'd spent months and months with consumers designing it. So we rejigged it, and then that went up to about 80%. So in the trickiest population you can imagine, lots of criminal involvement, lots of mental health involvement, lots of stigmatised groups and pressured groups, 80% of the patients and their carers said, yes, we're very happy. So there is no evidence for us taking this stance, as you say. It's just in the system, we're all falling for the trap, and I think we could proactively argue for an an automatic opt-in and an elective opt-out system, especially as we know we can manage data in a de-identified way. We can protect, the individuals are well protected in this current legislative environment.
Further questions from the floor?
Do you mind if I just follow on from that, Fiona? Because I think it's all about culture. I mean, it's all about culture too, but it is about setting the culture in the organisation, whatever it is, and that's something. I mean, I'm the clinical research director of the Women's and Children's Health Network, and that's the first thing we've needed to do to really embed research, and that's the terms I use. We're embedding research in everything we do at the Women's and Children's Health Network. Now, I know that's a vision and that's a hard thing to do, but I expect that from the CEO and I expect that from the exec, that they understand that we're embedding research in everything we do, and then we work towards that. So I just think it's a culture, but I mean, that's not a, it's so that when you're going on the wards to enrol a patient, you're not getting someone raise their eyes at you because you're an inconvenience to what's going on in the ward, but it's a lot of work.
Further questions? If there's not, I'm going to ask each of the committee to respond to a very simple question, which is what single bit of advice would you give to Natasha sitting in the office in Canberra that she would pass on to the Minister that is necessary to improve the health and medical research output of this country?
Maybe I'll start with that, and I think it relates to something John said earlier about the strategic examination of research and development. So just to make you aware, this is a completely different process to the National Health and Medical Research Strategy. So the National Health and Medical Research Strategy is being run by Department of Health, whereas the strategic examination of research and development is being run by Ministers in Education, Industry and Treasury, and health is not represented despite 25% of R&D being spent on health. So to that person, I just think there needs to be a lot of communication between these different portfolios in government, and they really need to work together, and we need to point out that, it's not okay that health is not represented in that strategic R&D examination.
So I would ask them to take a good hard look at the impact that capping international students is going to have on the ability of our universities to co-fund and fund the health and medical research that we do. So when we look at the government's own figures on expenditure on R&D, government is 0.16% of GDP, higher education 0.61% of GDP. So we spend 3- to 4-fold what the government does on R&D, and by putting in international caps, that is just going to reduce our overall capacity for R&D outside what's happening in the health system.
Well, I have said this to Natasha, so it's two things. It has to be inclusive, whatever we do, and it has to be embedded. It's got to be business as usual. If we can continue to consider R&D and innovation and research as completely separate from the delivery of healthcare and the prevention of healthcare and the management of health, then we'll face the same issues and the strategy won't be effective.
Well, I suppose I should answer my own question, which is that, or at least it's a difficult question to answer in a simple way, but what it boils down to is that the states get off far too lightly with the provision of both funding and facilities for the clinical research that gets done in this country. It's the states dump it all back onto the feds, and the feds don't produce. So that I think that the solution, well, the advice that I would give to Natasha is to basically hold the states to ransom. It worked in West Australia for a while. They got their extra resources, and the research output went up. Career structure was improved, and they were starting from a somewhat lower base, I might say, than some of the states, but they got there. I think that would, it's not that we want the federal government to give more money directly for medical research. We want them to put money into the health budget, which incorporates research as an integral part of healthcare. Because until we have that as a routine, we're always going to be trying to struggle to get things started, and then they'll disappear. Whereas if it's an integral part of healthcare and you can't do without it, then it just happens. Everybody gets trained in that area, and everybody who's trained in that area is at least given the opportunity to do research. They won't all want to, but at least they understand the message, and the message is that research is how you improve healthcare. If that hasn't stirred anything up from the audience, then go ahead. Please go ahead. We have another 10 minutes approximately we can use if we need to.
Yeah, so you've stirred up something there. Isn't that what the British health system did? So they went to the networks of the hospitals and they say, you should be integrating research, and then they say, yes, we have. And they say, well, show it to us, and they couldn't. So they said, okay, well, this is the percentage of your budget that should be in research, and they took it out. They said, okay, and then they made, is it NIHR or one of those acronyms, and then they said, okay, you've got to compete for it for research. So they actually made those systems invest in research by saying, well, you've got the money, we're giving it to you, you're not spending it like you should, so we're going to take that out, and then you've got to compete for it and demonstrate that you're doing that type of research, which I thought that's what they did. I got some nodding.
Yeah, that worked in Scotland extremely well. They chopped 3% out of the budget for the Lothian region because they said they were doing 3% of research. And then they did 3% of research when they got the money back. And it worked because there was a very entrepreneurial head of research for that Lothian Health District, Heather Kuby, who actually made it all happen. But it didn't work quite so well in the ones further south. They just took the money and ran. They got it back, and then they just spent more of it in healthcare. And it wasn't obvious that it was being spent on research at all. Frank?
Yeah, just following on that, I believe there is a federal fund that goes for teaching, training and research. And everything I've heard is that nobody can trace where that money goes, which seems like the situation which was attacked in the United Kingdom. So I think that they don't need to invent a new system they just need to have reports on what's been happening, and then things will happen. And I think although we've got many different aspects to thinking about the future and the strategy, it does come down to resources that are available. And going back to your involvement in the McKeown report, Ian, I think at the time it was something like 3% of the health budget should go into research. I think that's a simple, reasonable argument, and that the Academy could get behind that. And you can then justify 3%. But I think if you don't have something like that, we'll be having the continued problems.
Yeah, it was a pity the McEwan report got lost in a change of government. I think if that hadn't happened, we might have got the 3%. But that's the way the cookie crumbles, as they say. Maybe we can have another go at it. And it's if you could actually rely on the accounting system to be accurate enough to make you feel that you were getting your 3%, then it would be a good way to do it. Any further comments?
No, just maybe to comment on the TTR funding too, because that's something that, at a state level we've been really interested in. We set up a Research Directors Alliance, and I'm the chair of that. So we've actually taken that to our government, South Australian government, and as we came as one voice, and they've agreed to do a review of the TTR funding within our state, but also to think about how we can leverage more from Commonwealth. So it's something we're really interested in South Australia. Just to.
Anybody have a last question they want to ask? Because if not, I'll bring this session to a close and thank each of the three speakers, Professor Elizabeth Hartland, Professor Nowak, and Professor John Prins. Thank you all for your participation.